blood loss activates a number of homeostatic mechanisms designed to preserve perfusion to vital organs. The three major compensatory mechanisms that kick in during the early phases of hemorrhagic shock include catecholamine release, secretion of vasopressin secondary to non-osmotic stimulation of neurohypophysis, and finally, activation of RAS system and angiotensin II. The net result is profound vasoconstriction of vein and arteries, water conservation caused by vasopressin release, and increased heart rate, all of which are intended to maintain blood flow to the vital organs. Another feature of the severe hemorrhagic shock is so-called endotheliopathy. Hemorrhage induces profound changes in the vascular endothelium throughout the body. The mounting oxygen debt and the catecholamine surge eventually induce endotheliopathy through systemic shedding of the protective glycocalyx barrier, which results in increased permeability and activation of endothelium. This, in turn, leads to further loss of intravascular volume and causes systemic inflammatory reactions. Nearly a decade ago, a term of acute traumatic coagulopathy was introduced in human medical literature. Now, it is a well-recognized phenomenon in veterinary medicine as well. We also know now that it is an independent predictor for increased organ dysfunction and overall mortality in people. Coagulopathy in the acute phase of trauma or shock consists of two core components. First one is the traumatic shock-induced endogenous coagulopathy that occurs even prior to any resuscitation. The second is the resuscitation-associated coagulopathy. Tissue injury and severe tissue hyperperfusion leads to activation of multiple hemostatic pathways, including protein C thrombomodulin pathway, platelet dysfunction, and increased fibrinolysis. Endothelial damage leads to elevated levels of soluble thrombomodulin that binds to thrombin, which further activates protein C. In theory, activated protein C serves a protective function to maintain tissue perfusion by inhibiting thrombosis through inactivation of factors 5 and 8 and inhibiting plasminogen activator inhibitor 1, PAI1, during periods of decreased flow. However, in the face of extensive protein C release, this may result in massive fibrinolysis and hypocoagulable state. On the other hand, acidosis from severe hyperperfusion, the use of cold blood products and fluids, dilution of clotting factors further exacerbate clotting enzymatic system and lead to a vicious cycle of ongoing bleeding until the patient dies. Traditionally, hemorrhagic shock may be subdivided into three different stages. The early compensated phase of hemorrhagic shock is characterized by a potent vasoconstrictive response that may maintain normal blood pressure for quite some time. If the shock is left untreated, the compensatory mechanisms we talked about earlier get exhausted, and the patient develops early decompensated stage when the global tissue perfusion precipitously goes down, leading to oxygen debt. When the hemorrhage has progressed further, sympathetic excitation followed by inhibition and vasomotor paralysis occurs at the irreversible stage of hemorrhagic shock. Terminal phases of shock are marked by vasomotor dysfunction characterized by loss of arteriolar tone with paradoxically increased venular resistance. It can lead to vasodilation that doesn't respond to conventional resuscitation strategies. Progressive hypotension, refractory to fluid infusion, and vasopressors result in worsening tissue hyperperfusion, acidosis, and organ failure. There are three main reasons why decompensated hemorrhagic shock has a phenotype of vasodilatory shock similar to septic shock. In decompensated hemorrhagic shock, nitric oxide production is increased as a result of increased expression of the inducible form of nitric oxide synthase, all of which contributes to vasodilation. Normally, vasopressin plays a minor part in arterial pressure regulation, but in response to hypotension, such as that due to hemorrhage, it is released from the neurohypophysis and its concentration in plasma markedly increases. During the initial phase of hemorrhagic shock, vasopressin contributes to the maintenance of arterial pressure. As shock worsens, the initially very high concentrations of vasopressin in plasma decreases. The exact mechanism responsible for these low concentrations remain to be determined, but it is known that neurohypophyseal stores of vasopressin may be depleted after profound stimulation caused by severe shock state. Correction of the inappropriately low plasma vasopressin concentrations in vasodilatory shock by administration of the hormone at doses yielding concentrations similar to those found in acute hypertension significantly increases arterial pressure. Final mechanism of vasodilation in severe hemorrhagic shock is an activation of the potassium ATP channels in the plasma membrane of vascular smooth muscle. This results in efflux of potassium out of the cells, resulting in hyperpolarization of the membrane that prevents the calcium that mediates norepi and angiotensin II-induced vasoconstriction from entering the cell. Hence, hypotension and vasodilation persist despite high plasma concentration of these hormones. Interestingly enough, numerous experimental studies of canine hemorrhagic shock models showed that delayed blood transfusion fails to save these animals. This figure here shows an experiment performed by Wiggers in 1945 that demonstrates the effects of different degrees of sudden acute hemorrhage on the subsequent course of arterial blood pressure. All animals were anesthetized and divided into 6 groups. They were all stable at baseline with a systolic blood pressure of 100 millimeters of mercury. Then they were bled rapidly until their arterial pressure fell to different levels. Those animals whose pressures fell immediately to no lower than 45 millimeters of mercury, which are groups 1, 2, and 3, eventually recovered. The recovery occurred rapidly if the pressure fell only slightly, such as in a group 1, but occurred slowly if the systolic blood pressure fell almost to the 45 millimeter of mercury level, which is group 3. All dogs whose arterial pressure fell below 45 millimeters of mercury, groups 4, 5, and 6, died despite the blood transfusion and full resuscitation. However, many of them hovered between life and death for hours before the circulatory system deteriorated to the stage of death. This experiment demonstrates that hemorrhage beyond a certain critical level causes shock to become progressive. That is, the shock itself causes more shock, and the condition becomes a vicious cycle that eventually leads to deterioration of the circulation and results in death.